You're listening to WUSB Stony Brook. Habanero here with the business of healthcare. We come to you every other Friday afternoon between 1 and 3 p.m. And we are alternating with Chris Sorochin and If This Be Treason. So I don't know how they put us together, but it's been done. So hopefully you are enjoying the summer. It's like finally gotten here, right? And I know I am. And I have not been able to get out there as much as I like. And I feel like a combination of working too much and the weather. We had definitely some weather hiccups in our spring leading into our summer. And just haven't been able to get out and enjoy the summer as much as I'd like to so far, but hoping to remedy that soon. Let us get started. You're listening to WUSB Stony Brook. You can hear us at 90.1 FM or 107.3 FM, and you can also listen online at WUSB.FM. The programming you put together here today is directed to patients and providers alike. The healthcare reimbursement world has really changed over the last few years, and it looks like it's gearing up to be changing again as we speak. And so the question that I pose to you, the listener, is what changes do you need to embrace to make the best use of this current system? So it's certainly possible and very commonplace for people to whine and complain about what is going to be, what might happen. But let's talk about the things that we are presently faced with. You know, in the olden days, as a patient, you just needed to arm yourself with medical-related questions when you prepared to see a medical practitioner. Well, today, you almost need to treat it like a meeting with your accountant, your attorney, and your financial planner all rolled up into one. I know I've had that experience recently. Something that I thought was going to be relatively straightforward turns out 4-digit check that I was expected to write for it. And just kind of threw me for a total loop there. If you're a medical practitioner, you're on the opposite end of that, right? You used to need to just dig out your best bedside manner and have the most current and the most tried and true medical practices, and you were prepared to see your patients. Well, today you're almost in the same boat as those patients. You need to be thinking like your accountant, your attorney, and a game show host contestant, since so many patients come in throwing curveballs that have been lobbed by their brother-in-law who's a physician's assistant, or the television talk shows, or WebMD, right? So I prepared a couple topics to discuss today, interspersed with a little bit of funkin' A music. If you've got questions or topics you'd like to know more about, you can reach me 631-244-5661, or you can send me an email to habanero@wusb.fm. You won't want me to ask me any clinical questions, only the financial and business office end of things. You definitely don't want me near any of your patients. What I wanted to talk about today is Medicaid. And I think that there are so many facets to Medicaid that people have a different or maybe a wrong impression about it sometimes, because Medicaid has this connotation that it is for those people, right? It's not for regular people that you might know or be. It's and when the conversations come up about Medicaid, people are like, well, why don't those people get a job? Well, I think people don't understand that so many jobs today don't provide health insurance. Years ago, it was a given. If you had a full-time job, you had health insurance, no matter what that job was. There are a lot of people who either work multiple jobs that aren't necessarily full-time, or plenty of people with full-time jobs that don't provide benefits. And depending on what your income is or what your health status is, you might very well be fully employed. yet eligible for Medicaid. But that doesn't mean that there aren't people who take advantage of the public assistance systems. And I think that's another one of the things that kind of sparks people to be upset about the current state. So what I'm going to do today is investigate a few different aspects of Medicaid. And what's one of the things that got me started on this? Well, in New Jersey, there is currently a very high-profile situation unfolding. And I'm going to read a little bit from the USA Today article from last week. New Jersey welfare fraud arrests spark anti-Semitic sentiment. Authorities arrested 6 more Lakewood residents on charges of public assistance fraud in a second round of raids in the town late Tuesday. Again, this was last week. The social media comments on Facebook and other news sites were raw and hateful. The outpouring of invectives was sparked by the arrest last week of 14 residents of Lakewood, New Jersey, including the rabbi of a congregation on public assistance fraud charges. The early morning raids ignited a firestorm of anti-Semitism against a municipality of 100,000 that has a majority of Orthodox Jewish residents. The allegations and the charges levied against the defendants have nothing to do with their religion, said Joshua Cohen, the regional director of the Anti-Defamation League in the New Jersey region. That's why we're deeply concerned when we see comments online, whether it's on newspaper websites or social media, that are anti-Semitic. The hate speech moved off the internet into the streets. Hate flyers spread around the township over the weekend, said residents who provided photos of the flyers. And some other really nasty stuff happened that's being investigated. We do believe that this recent rash of anti-Semitic incidents is directly related to the recent arrests in our town. We've not had any other incidents like this before, said the police chief. We'll not tolerate this kind of behavior, and we're working with the state and Ocean County in an attempt to make arrests. We'll look to prosecute all incidents of bias crimes that take place against our citizens. So I would just point out that there are probably quite a few different places in the country and probably around the world where things start happening in a certain area and right away people start pointing fingers and tempers rise, I should say. Many of the online comments zeroed in on the religion of the accused and made sweeping, disparaging, and dehumanizing statements about all Jewish people. Although the primary vehicle for these comments was social media, some Lakewood residents had experienced it in person. So they go on to talk about these things that have been happening. But what was the root of all of this? Well, part of it is, the author of this article says, is to understand Orthodox Judaism. The ways of life of various Orthodox groups aren't necessarily looked upon favorably by modern society. That's a sociology professor at Yale. People have every right to criticize a group that lives in a way that isn't open and democratic and tolerant. Those are things we have to defend. At the same time, we have to be tolerant of minorities who are different, even if they're different in ways we don't approve of. Orthodox subscribe to the idea that they're a separate society, says Samuel Heilman, a sociology professor at CUNY whose expertise is Orthodox Judaism. Orthodox members dress differently, act differently, and separate themselves from American laws and societal norms. Orthodox identity is forged in a world where the outside community is seen as hostile. It's hard to persuade them that they're no longer living in a world where they want all the Jews dead. 50 to 65% of the Orthodox in Lakewood, New Jersey, live below the poverty level. In many ways, the Orthodox are impoverished by choice. Many are not college educated. Most marry early, have large families, and don't see public assistance as an embarrassment. It's not a matter of political corruption. It's a matter of moral blindness. And that is from, again, the professor who studies this group. Americans, with all their claims of multiculturalism, don't like people who are different. They don't like people who don't speak English. They don't like people who don't fit in, and many Orthodox Jews recognize this hostility. The cliquishness of the Orthodox and the facts that they speak Yiddish in America creates xenophobia and prejudice. It's perceived as anti-Semitism by the Semites. By outsiders, it's perceived as a legitimate gripe against people who they see as taking advantage of the system. Most people don't understand the lifestyle of observant couples. There are thousands of hardworking families juggling multiple jobs, studying, and taking care of 4 to 6 children. It's not an easy life. It's not a community of freeloaders. It's a community that's trying to make ends meet. He says some families don't cross the line when it comes for applying for public assistance, but it's also common for families to get caught in the gray area. A process varies from agency to agency, and all these different programs can be overly complicated. Overall, the real tragedy here is that families get caught up in this, and the hate mongers go loose. So what I would argue is that you could substitute Orthodox Jews for a number of other groups that are perceived as taking advantage of our welfare systems, right? Whatever they might be. So there are people who say that there are different minorities who don't want to work and have different lifestyles, don't want to speak the language, and are taking advantage. That often pertains to inner city groups. That's the groups that we might be more familiar with here in the Northeast. If you lived in the western part of the country, you might see the FLDS, Fundamentalist Latter-day Saints, which is a sect of the Mormon community in that category. They have a lot of the same views. They consider themselves to be completely different from the rest of society. They have different familial ideas, what constitutes a family and how big a family is supposed to be, and perceived perhaps a lack of embarrassment of being on public assistance as well. So, there's all different kinds of groups that might be perceived as taking advantage of what we consider our welfare system. So there's 2 other groups that come to my mind in this conversation. And the first is something that many of you might not be intimately familiar with, but I will guarantee you that in your friends and family and neighbors and acquaintances, there's definitely at least one, and that's somebody who receives state and federal public assistance because of a handicapped child. So whether that is medical assistance for a severely medically dependent child, perhaps one who is living on a ventilator or is just otherwise severely handicapped, or even family members who might be in those categories. Public assistance helps those people. And right or wrong, corporations, who are now people too, have a significant welfare system that they also take advantage of. All things to consider when we start a discussion about what is the Medicaid system, and if you're listening to some of the current debate that's going on regarding these continued efforts to modify and fine-tune and or throw out and replace, repeal and replace our healthcare programs here in this country, Medicaid has become a big topic of conversation. So again, what I wanted to do today in today's program is dig a little bit more into that, hopefully provide a little bit more information, a little bit more education on what is Medicaid, who's really covered, what kinds of programs, what kind of money is involved, where does it go, and maybe why people shouldn't be so eager to want to dump the freeloaders or those people, as often the perception is. Okay, so one of the things that I wanted to do was to get some basic information about how Medicaid works and who it covers. It's become one of the biggest flashpoints in the debate over the Republican legislation to repeal and replace the Affordable Care Act. So I wanted to put together some basic facts about the 52-year-old Medicaid program. So Medicaid, not to be confused with Medicare, Medicaid is a public health insurance program largely for low-income people, although some middle-class disabled and elderly also qualify. The state and the federal government share these costs. Nearly 1 in 5 Americans, or 74 million people, are on Medicaid. Federal law guarantees Medicaid coverage to pregnant women, children, elderly, and disabled people under certain income levels. It covers more than a third of the nation's children and pays for half of all births. It also covers almost 2/3 of nursing home residents, including many who are middle class and spent all of their savings on care before coming eligible, or have been able to arrange their finances through strategic planning to dispose of all of their savings on paper so that they can qualify for Medicaid. States also, of course, none of us know anyone who would do something like that so that they could take advantage of Medicaid people, because wouldn't want to be one of those people, right? States also have the option of covering other groups like children and pregnant women whose household incomes are higher than the federal thresholds, or young adults up to age 26 who were once in foster care. The Affordable Care Act allowed a new optional group, adults with income up to 138% of the poverty level, which would be $16,643 for an individual this year. So again, if you're earning more than $16,643 a year, you are 138% above the poverty level, and you probably wouldn't qualify for public assistance or for Medicaid. 31 states offer Medicaid to people who are earning less than the $16,000. In 1965, just for a little bit of history, it was created as part of Lyndon Johnson's Great Society. There wasn't a lot of political debate. The bigger fight was about Medicare, and Medicaid is often confused. Medicare is primarily for the elderly and the disabled, whereas Medicaid is more for people who are either financially or medically indigent. So Medicaid is an entitlement program. Anyone who meets the eligibility rules has a right to Medicaid coverage. And for now, states are guaranteed open-ended financial support for their Medicaid programs from the federal government. So that doesn't mean the federal government is paying for everything. There are expenses are shared with the states, and it depends. Different states get different amounts. So Medicaid cost an awful lot of money. In 2016, it was $553 billion. Of that amount, $348 billion came from the federal government, with the states paying about $205 billion. Medicaid accounts for 9% of federal domestic spending. So for states, it's the biggest source of federal funding and the second largest budget item behind education. So it's big. It's big. The biggest Medicaid costs are for the elderly and the disabled, usually because of long-term care in nursing homes. You know, people who think that it is one of those people who's having extra children, that's not where your Medicaid dollars are going. Your Medicaid dollars the majority of them go to nursing care homes for people, which, you know, as the population ages, that need is only going to increase. As population increases and the population ages, and as they've got more and more things that they can do to prevent people from crossing over, the need for nursing home beds is just going to increase. Washington pays for 50 to 75% of Medicaid costs for most eligible groups, with poor states receiving more money. Under the Affordable Care Act, the federal government initially covered all of the costs for the roughly 11 million people insured under the law's expansion of Medicaid, and that's largely adults without disabilities. So again, that would be potentially quite a few of your friends or family or neighbors, or maybe you. Under the law, Washington picks up 95% of the state costs for the expansion in Medicaid, and that is projected to decrease little by little until being about 90% in 2020. And I think that's what is at stake in a lot of this wrangling over the healthcare bill and the changes that predominantly the Republicans want to implement. And that is to chop out that federal share and have the federal government paying less for medical expenses for people in the Medicaid program. Okay, this is a pretty recent article. So what changes are in store? So both the House and the Senate bills would fundamentally change the way the federal government pays its share of Medicaid costs, setting a per-person limit on spending that would adjust annually for inflation. One of the projects, I think, as people know, this is a world that I work in. I work in healthcare, and I work in the behind-the-scenes money end of things. So if I've got a really sick child who is severely disabled, and I'm currently getting help with their care from the Medicaid program, setting a per-person limit on spending is going to be a big problem for me, whether or not it's adjusted annually for inflation. Because when you've got someone who's so sick that they are having 24-hour nursing care to take care of them because they're on a ventilator, or their health condition is so precarious that it requires having not someone around to give them a bath or to change them, but someone to make sure that medically they stay alive, and if something goes wrong, there's a medically qualified person available immediately to take care of anything that comes up. That's where an awful lot of this money goes. Bills, okay, just back to our statistics here. The bills that are being proposed by the House and the Senate would also effectively end the Medicaid expansion by sharply reducing how much the federal government pays for that population starting in 2020. So the interesting thing to me about that is it is setting the stage that until next time our country has to make big political decisions, things would stay pretty much the same in that arena for the Medicaid expansion. So that's actually one of the things that makes me think that maybe this isn't quite the crisis it's being led up to be, because when you have things that are going to take effect in years to come, there's a lot of opportunity to have that changed. So the result of these changes that are being proposed would be major reductions in Medicaid federal spending over time, which is what the objective is, right? So the objective is to say the federal government should not be in the business of providing all this health care or paying for all this health care. So the question to me is, if the federal government isn't paying for it, and the state certainly can't afford to pay for it, what should happen to those people? If you happen to be someone who's got a severely disabled family member, or maybe if you develop potentially terminal or fatal disease that could be cured with a medical intervention, does that mean that if you can't afford it, you're just kind of like out of luck? Bye-bye? Or is there some obligation to provide care to people? And if there is an obligation, what are the parameters of that? And I think that's kind of where a lot of this, to me, winds up. So A lot of times when I get into these conversations with these people, I know that, or I'll pull up an example of maybe somebody that they might not be aware of and say, well, did you know that Joe and Mary have a really sick child? And yes, of course, they both work full time. They have good jobs, but they've got 24-hour care to help take care of their child. So what do you think that they should have to sell their home and bankrupt themselves so that they can take care of that child? Or maybe that child should just be kind of let go so that they're not a fiscal burden any longer on the family or the society? Talk to me about what do you think should really happen with that? And 9 times out of 10, the conversation comes around to say, I'm not talking about them. I'm talking about, those other people. And, of course, they don't want to come across as being called any of those names, so they won't give you too many details about who those people are, although sometimes they might. They'll talk about, those people that aren't working, or those people that have all these kids, or those people who aren't supposed to be here. And again, then you wind back around and say, well, what about Sarah and John? They're in that situation. Well, no, I'm not talking about them. Of course, they're nice people, they work, blah, blah, blah. Once you start having those conversations with people, they shut you down because they don't really, you're not following their line of thinking. But that's, to me, the kind of thing that people really need to think about when they challenge these proposed restrictions or changes or pulling the rug out from under people. I'm not saying that there aren't things that could be changed, or perhaps things that Medicaid shouldn't be spending for. For example, I remember the outrage when people realized that Medicaid was not paying for birth control, yet they were filling Viagra prescriptions because, that's what patients wanted, and that's what people figured out how to wangle their way around the rules. But that's the kind of thing that I think, if you're going to look to where to make adjustments, setting a per person limit on spending that would adjust annually for inflation is maybe not the way we're going to get there. The other thing that they're hoping is that enrollment would drop in these programs, and it would make it harder for states, or states would make it harder for individuals to qualify for the programs, and they would be getting rid of certain benefits to make up for tightened federal spending. So I'm going to kind of redirect this thing around again. And if people aren't covered, or if people don't have access to health care, when they, for example, develop a nasty cough that is persistent and just gets worse, instead of making it possible for them to go to their doctor and get a checkup and perhaps have a chest x-ray, makes no sense to wait until they are in full-blown pneumonia and then require a hospital stay. And what do people propose happens with that hospital stay, right? Does the hospital turn the patient away? Is the hospital expected to eat the providing of that service? Because again, we've got someone who can't pay for it no matter what happens. They're someone that's living too close to the line and don't have the means to pay for that stuff. So what exactly that's what I find happens with these things. It's great to talk about broad strokes and ideas and categories, but when you are looking at that person in the face and telling them, what do you think they should do? That's where I want people who want to make these broad stroke changes to think about. So how did this used to happen? So the way this used to happen is that person would wait until they were pretty sick, or maybe not. Maybe they would go to the hospital when they just had a cough, and people would call that abusing the emergency room. Okay, that probably is an abuse of the emergency room because it could be better treated just going to your local doctor, to your family physician. But if you don't have access to that, you go to the emergency room. And if you then waited too long and were real sick and had to be in the hospital to treat that pneumonia for a few days or a few weeks, the hospital would take care of you, and the federal government would settle up with the hospital at the end of the year. Hospitals have to file these big fancy paperwork things called a cost report at the end of the year. And at that point, the hospital can say, well, Mary Smith came in and we either treated her in the emergency room or we treated her for a few days. She stayed with us and we took care of her infection. And we didn't get paid for that because, she didn't have any insurance. So that would be settled out in the cost report at the end of the year. It's a thing called disproportionate share, and it is a payment that's made to hospitals when they care for a disproportionate share of a medically indigent population, which is what this category would be. Well, one of the big things that Obamacare did that people probably who weren't into the nuance of it didn't realize was Obamacare said, we want everybody to have insurance so that they can be encouraged to go to their regular doctor and not show up at the hospital or the emergency room. And we are going to not be paying hospitals for this disproportionate share stuff anymore. So that's where a lot of the funding is going to come. People would sit there and say, how do they think they're going to pay for this? Well, people don't realize you pay one way or the other, right? As a taxpayer, we don't, as a society, say, you're sick, you don't have insurance. Well, be like a dog and go crawl into the woods to die. We don't do that. We take care of people, and it gets paid for one way or the other. So that's really a lot of what my take is on a lot of this argument over how do we pay for this stuff? You're going to pay for it one way or the other, right? Why not go along with a more organized, financially structured mechanism for doing it, which is insurance, right? You're listening to WUSB Stony Brook on July 14th. It's a Friday afternoon, and we're talking about the business of healthcare. So today on the business of healthcare, where we talk about information that hopefully expands your knowledge base, whether you're a patient or a provider of medical services, or maybe you even just work in a provider's office. People have such different connotations about healthcare, and so many things have changed recently. It used to be that Medicaid took care of a specific population. But as people have had better access to medical care, as the idea of accessing medical care has expanded, as the medical industry has come up with solutions to so many things that used to do people in, right? If your child was born too prematurely, as sad as it was, a lot of times that child just didn't make it. And now there are all different kinds of things that can be done to maintain someone's life. And whatever your feelings might be about that, it's a service that's provided, and there's a lot of people that take advantage of it. Same thing at the end of life, right? There are a lot of people who in past years might have developed a condition, whether it was a cancer or a cardiac event or just a deterioration of mind or body, who would have in the past passed. But now we've been given all of these miracles of continuing someone's life. And again, however you might feel about that, it's a reality. So that's one of the many ways that the Medicaid program has expanded, because it's not possible for almost anyone to care for someone who gets into that high a level of medical dependence. And honestly, the people who could afford it are the first ones to figure out how to help get somebody else to pay for it. So All right, let's get into some information about Medicaid in the state of New York. And this is from the Kaiser Family Foundation, June 2017, so it's pretty current statistics. Medicaid and the CHIP program, which is the Children's Health Insurance Program, provide health and long-term care coverage to more than 6.4 million low-income children, pregnant women, adults, seniors, and people with disabilities in New York. Medicaid is a major source of funding for safety net hospitals and nursing homes. The American Health Care Act, the AHCA, would fundamentally change the scope of the program and end the guarantee of federal matching funds. So while this might be looking to drive you to a particular conclusion, I'm going to just stick to the present day facts that are presented here rather than getting into the discussion of what might change. So right now, there are 19.7 million people who live in New York. 31% of our population is considered low income. And low income is defined as less than 200% of the federal poverty level. That amount, 200% of the federal poverty level, is considered to be $40,800 for a family of three. So think about you and your family and what your income is and on what side of that 40,000 you are. And that would tell whether or not you're considered one of New York State's 31% of the low-income population. So what else do we have? 24% of the people in New York were covered by Medicaid or CHIP. So 24% are covered by CHIP or Medicaid. 50% have employer-based insurance. 13% have Medicare. And 6% are uninsured. That's a lot of people, 24% of the population, including children, because the children make up a huge percentage of that, rely on Medicaid for their health care. I'll tell you another thing that I always find interesting. A lot of times when I go to work with a medical practice, actually less so now, but people would say, oh no, we don't take Medicaid. I would say, I bet you do, because Medicaid isn't the same program that it was years ago. And if you are taking United Healthcare or a whole host of different insurance, chances are that there's somebody in your patient roster that is in one of the Medicaid programs that one of those regular insurance companies provides. So people who say they don't take Medicaid probably don't have a good enough handle on their exact payer mix. Okay, so since the implementation of the Affordable Care Act, Medicaid enrollment has increased in New York. So there used to be 5.7 million people on Medicaid, and now we've got 6.4 million people on Medicaid. Medicaid expanded through the Affordable Care Act, adding an additional 2.2 million adults in the Medicaid expansion program. And the uninsured rate in New York has decreased. So this is one of the statistics that I think people don't pay attention to. So there used to, in 2013, 10% of the New York population was uninsured. So they would come to the hospital or the emergency room, because when you don't have insurance, that's where you have to go when you're sick. 10% of them had no insurance. So they were either paying themselves or the hospital was eating it. That has gone down almost in half. New York has 6% uninsured population as of 2015. That is a terrific statistic, because that means that there are more people that have access to insurance that didn't before. Now, again, one of the things I know I'm kind of, if you're paying attention to me, you're hearing that I'm drumming this in, but just because someone doesn't have insurance doesn't mean they're not going to be accessing medical care. So they might not be going every year for a physical. They might not be going and having that lump taken care of or that nasty cough taken care of when it starts. But when they're on the verge of dying from it, or when they're extremely compromised and need much more expensive and intensive medical care, is when they're going to present for their health care. So just because they don't have the coverage doesn't mean you're not going to wind up paying for it one way or the other. All right, so Medicaid covers in New York 1 in 5 adults that are under the age of 65, 1 in 2 low-income families, 2 out of 5 children, 2 out of 3 nursing home residents, and half of the people with disabilities. 78% of adult and child Medicaid enrollees in New York are members of a family with a worker. So it's not like all of these people don't work. It's not even that the majority of these people don't work. Almost 80% of them have somebody in the family in the workforce. So the picture has changed so much since, maybe 10 or 15 years ago, when if you worked, you had insurance. If you didn't work, well, those were the people who were more likely to be on Medicaid. So this idea that why don't those people work? They're working. Okay. So nationally, Medicaid is comparable to private insurance for access and satisfaction. So if you look at these statistics, they've compared, child care checkups, doctor's visits for adults, specialist visits, and just in general, adults are satisfied with their health care. If you're on Medicaid or if you have regular insurance, it's providing a satisfactory level of care. Now, if you're uninsured, it's terrible. The statistics are terrible. Less than half the people are ever satisfied. Medicaid coverage contributes to positive outcomes. So it results in declines in infant and child mortality rates. Long-term health and educational gains for children are documented. So if you have a child who has access to health care, they're less likely to develop long-term health problems that, guess what? You as the taxpayer would wind up paying for anyway. So it's to the society's advantage to provide people with the basics of health care. Each Medicaid program is unique, so every state gets to decide what kind of options they'd like to offer on expanding the coverage for children, and many states opt to expand coverage for other groups, not just children. All states offer optional benefits, including prescription drugs, long-term care in the community. States can choose how they want to deliver their additional services on top of the basic federal benefits, and how they're going to pay for them, right? And there's all kinds of innovation going on with state Medicaid programs across the country. They are testing new payment models to better integrate and coordinate care to improve health outcomes. So I'll give you a perfect example. This doesn't happen so much in New York, but in a lot of very rural areas, people don't have access to health care because it's literally just too far away. So what states might do is they might say, listen, we're going to provide telehealth benefits. We're going to provide maybe people with a cardiac condition or with diabetes with equipment that they can use in their home, and they can weekly, daily, monthly report in medical statistics to a doctor's office or a clinic, and we can monitor you from afar. And if everything's going well and things look good, don't come in. Stay home. Keep doing what you're doing. But if your heart rate increases, if your oxygen level decreases, if your murmur starts to act up or your AFib, come in. Then we need to come see you, make the trip to see your medical provider. Those are all things that you might not be aware of as the patient that are clinical indications that you need to come in and see a provider. So those are examples of things that states can make changes in and say, we're going to do things a little differently. And they can also, states also have the option to use Medicaid to address specific issues. So, for example, I'll give you a perfect example. New York, believe it or not, I know there's a lot of criticism about this, but New York has done quite a number of things ahead of other states to address the opioid epidemic. So, for some time now, they have had an I-Stop program, which every provider who is going to prescribe certain types of controlled substances, they must document that they logged into this iStop system and researched that patient to see, is that patient getting prescription drugs from another provider? Has this patient had an addiction problem in the past? And it doesn't mean that they're not going to treat those patients, but it requires the provider to get the information so that they can use that to help them decide how they're going to make a better medical decision with how they're going to treat that patient. So that's a big, fancy, expensive program that a lot of providers don't like having to deal with because it's not easy, surprise, surprise, to get in there and use it. A lot of southern states are worried about Zika, so they've been able to say, we're going to use some of our Medicaid funding and our Medicaid dollars to address that. Autism, dementia, environmental health emergencies, right? So there are some states that have different things going on that they want to use their Medicaid dollars to address. We are talking about the business of healthcare, and we're talking about your Medicaid dollars and getting a better understanding of, some of the different factors that are around Medicaid spending, because that's one of the big areas that's being targeted in the AHCA, which is better known as the Republican attempt to repeal and replace the Affordable Care Act, also known as Obamacare. We are going to take a quick musical break again. We'll hear something else from Funkin' A, and then we're going to come back and we're going to talk about some more specific examples of things that do happen with the funding in these programs and what kinds of abuses they are looking to address. Our next little segment here today, you're listening to WUSB Stony Brook, the business of healthcare with Habanero, and we are discussing or trying to give a wider view of issues around Medicaid, the Medicaid program. I think a lot of times people don't understand the nuances of the program. So I wanted to share some information, and that's what we've been doing the program. What kinds of things are going on today in Medicaid? What are some of the reasons that a lot of people think there need to be changes in the Medicaid program? So here's an example of one. So 7 couples from the same town in New Jersey have been charged with public benefits fraud. This is a widely published story, but I'm going to take some information here from, this is the AP. 7 married couples from the same New Jersey town, Lakewood, New Jersey, including a rabbi and his wife, now face charges that they misrepresented their income to get a combined $2 million in public welfare benefits they weren't entitled to. So this is very recent. This has just happened within the past week. 3 couples were arrested last week after 4 couples were arrested earlier in the week. 3 couples were released without bail after appearing through a video conference in a state court on Wednesday. It wasn't immediately clear if they had attorneys who would comment on their behalf. But these 3 couples misrepresented their income and then collected more than almost $700,000 in benefits. These couples failed to disclose income from numerous sources on applications for Medicaid, housing, Social Security, and food assistance benefits. The federal investigation centered on Lakewood, which is home to a large and growing ultra-Orthodox Jewish community. One of the accused previously ran a school in Lakewood for special needs students that closed in 2015 after facing more than $250,000 in federal and state tax liens. It really bothers me when people take advantage of programs like this, said the mayor of Lakewood. He's got a waiting list of Section 8 vouchers for housing assistance of maybe 2,000 families that really need it. And I just hate to see things like this when people cheat to get themselves bumped up on the eligibility list. So the Chamber of Commerce told the newspaper that thousands of Jewish families in Lakewood need public assistance, but some are tempted to take more than they need. The pressure of the community overhead, especially the costs of private schooling, is unsustainable. People are forced to find ways to bend the system. Lakewood, and this is, who is this? The leader of the Orthodox Jewish Chamber of Commerce. Lakewood is the state's fastest growing town and has more than 100 private religious schools. The population increase has intensified concern over how public money is spent and sparked complaints from neighboring communities that say they face overly aggressive solicitation from real estate agents looking to find homes for the Jewish community. The town had nearly 93,000 residents in 2010, up from about 32,000 more than a decade earlier. Estimates are it's currently closer to 120,000. The arrests on Monday, one family was charged with collecting more than $330,000 in benefits. They were charged in court with another family charged with collecting $585,000 in benefits they weren't entitled to. They made more than $1 million, both of these families, in 2012 and 2013, but still received more than $96,000 in Medicaid benefits, including $22,000 to pay for medical expenses when their sixth child was born. Everything's going to work out and we'll all be vindicated, the wife was sure of. According to the federal complaint, the one family hid their income by creating companies that were run by relatives on paper, but the couple actually controlled. They made a total of $1.8 million, but still received Medicaid, food benefits, and housing assistance into 2014. So those are the kinds of charges that are being made against that organization. And there is another one here from another group, so that nobody thinks I'm picking on one particular group or another. In the litany of evils perpetrated by polygamists, one evil stands out above the rest, and that's tax evasion. So this is from the polygamous tax evasion. So this references the FLDS, the Fundamentalist Latter-day Saints, and that is a sect of the Mormon community. It's one of the things that they're accused of doing. So there's a couple of different allegations that members of a southern Utah polygamous sect are guilty of widespread welfare fraud were raised repeatedly during a U.S. Judiciary Committee hearing a couple of years ago. They resurfaced frequently, too, in a message sent to Texas Governor Rick Perry after raids on the branches of the Fundamentalist Church of Jesus Christ of Latter-day Saints. Welfare data, it does not always support the claims. While many families living in the sect's traditional home base receive food and medical help, virtually all of those families qualify under the program guidelines. One of the reasons for that is that they have this concept known as bleeding the beast, which is defined as including applying for every possible type of government assistance that's available. This one particular community received 8 times the welfare assistance of comparable sized towns in the area. You know, there are a lot of people who would say that the way they manage their tax obligations is by taking advantage of every possible loophole or available deduction possible. So I often ask people, what are the differences? How do you differentiate between maximizing your ability to take care of yourself and your family by taking advantage of everything that you can or not? So, of course, in a FLDS community, there happens to be an awful lot of single-parent families because they're only allowed to claim one spouse, and sometimes there are multiple adults in what's considered a family, but the other adults in the family can be eligible for public assistance or Medicaid based on their single parent status. So that's one of the areas that is often brought out when talking about public assistance issues, right? Medicaid and the use of Medicaid funds. Well, let's listen to Take a Back Seat on Funkin' A. And then we'll come back with a little more discussion about other states and some of the challenges that they're facing as they continue to try to manage this whole Medicaid world. We're talking today about Medicaid, and the reason we're talking about Medicaid is because it's become a primary focus in the GOP's striving to repeal and replace the Affordable Care Act. There are an awful lot of people that think that Medicaid just takes up way too much of our spending. I'm not sure I disagree with them, but the question becomes, how do you manage that? What are the kinds of things that you look to carve up or trim out or get a better handle on in order to better manage providing health care to people in our society? And again, one of the things that I've been stressing is, we're not talking about who can be eligible for a facelift. We're talking the basics of healthcare. That's really kind of where we're looking to focus. So states are moving to tighten Medicaid enrollment, even without a new health law. No corner of the health system would be harder hit than Medicaid. And that is, as we have been discussing, it's the federal and state health insurance program for the poor. Not just the poor, the financially poor and the medically indigent, which means people who have complicated, expensive medical conditions. If Republican leaders in Congress round up the votes to repeal major portions of the Affordable Care Act, that's what's going to happen. GOP lawmakers have proposed winding down the Medicaid expansion that added 17 million people in 31 states and the District of Columbia under the ACA, eventually capping the program's spending per person. If the current bill in the Senate becomes law, 15 million fewer people would have coverage through Medicaid by 2026. So again, another thing to point out is some of this stuff is a little, I don't want to say Chicken Little oriented, but when you talk about things that aren't going to be implemented for another 4 or 10 years, there's a lot of changes that can be made in that time period. So while it's important to pay attention to these things and make sure you understand them, it's equally important not to get hysterical about things that aren't going to change tomorrow. Other efforts that are garnering much less attention, however, would further reshape Medicaid, potentially knocking millions more off rolls. So that includes asking beneficiaries to verify their eligibility twice a year instead of once a year, which is the current law. So in many ways, the current battles pit those who view Medicaid as a health insurance program in which higher enrollment is not seen as a problem against those who see it as a welfare program in which lower enrollment is prized. Some states have experimented with more frequent verification of eligibility and other techniques to manage enrollment that they say have worked well. But other states have said, it's not cost effective to do that, and it's overly burdensome. So the Trump administration says it wants to let states experiment more with their Medicaid programs, inviting them to ask for waivers that don't need congressional approval. In recent months, states have proposed changes that include requiring all able-bodied adults on Medicaid to work. I don't know what that does when there's not jobs available for people. Drug testing enrollees, which is two problems with that. First of all, it hasn't been proven to be cost-effective. And second of all, if someone really is a drug addict, they aren't going to be able to work, and they need help to figure out how they're going to, if they're ever going to be able to get off it. You need help to do that. You need medical help to do that. Other things are capping the length of time that some can stay on the program, or limiting the number of people who can be on the program at once. The Obama administration had rebuffed some of these efforts in the past. All the bells and whistles and hoops that people have to jump through create an enormous amount of red tape, and that depresses enrollment. That's according to the director of the Center for Children and Families, a research center at Georgetown University. It is a proven strategy. So if you want to depress enrollment, make it more complicated. Some 74 million people are currently enrolled in Medicaid. Since the implementation of the Medicaid expansion under the Affordable Care Act, Medicaid enrollment has grown by 16.7 million. That increase alone is larger than the number of people who purchased health insurance through the marketplaces set up by the Affordable Care Act. Health policy researchers say there's ample evidence that adding paperwork and administrative burdens on beneficiaries in Medicaid increases turnover. For the most part, it's not because people are no longer eligible. It's that poor people frequently move and often face a host of challenges that make it less likely for them to turn in the required paperwork. Even before the ACA passed, many states were moving to make it easier for people, particularly children, to get enrolled and stay enrolled in Medicaid and the CHIP programs. That's the Children's Health Insurance Program. The Affordable Care Act allows states to formally reassess people's eligibility enrollment just once a year. But Medicaid enrollees are required to notify authorities in the interim if they have a major change, such as finding a job or moving out of state. The House bill requires reassessment every 6 months for enrollees who become eligible through the Medicaid expansion. Proponents say that too many people on Medicaid when they stay on Medicaid when they're no longer eligible. They point to Illinois, who hired a consultant a few years ago to help improve its renewal process. During the first 3 quarters, a whole bunch of people had their Medicaid canceled during the renewal process. The vast majority for not responding to requests for information. Of those, more than 25% eventually re-enrolled after submitting the requested information. Certainly, at least some percentage of the clients who did not respond did so because their circumstances were such that they were indeed not eligible. The people who are more likely to respond are those who are eligible. There is a contradictory thought that says that you make it too complicated and people will say, I don't need health insurance today, so I'm not worried about being enrolled for eligibility. Let the healthcare provider worry about it, or let me worry about it when I need medical care. And that's actually one of the big problems that happens. You make it more complicated. People don't care because even if they're eligible, they know if they show up for care, they will be taken care of. Okay. In Texas, people with fluctuating incomes risk being cut off from Medicaid. That's exactly what happened in Texas. The state regularly checks the finances of families whose children are enrolled. State data appears to show that the number of children experiencing a temporary gap in their Medicaid coverage has increased since the state instituted a new process to check eligibility in 2014. Letting states check people's eligibility more often, you're giving states a tool to make sure that people who are enrolled are the people who the program is meant to help. Well, that's not always the way it works, because if you've got someone who's got fluctuating income, they may be eligible this month but not eligible next month, and then back on eligibility the month after. So if you make the turnaround time and the requirements too complicated to go on and off, especially people who are trying to juggle large families and sporadic work, it's just not going to be a priority. So let's see what else. In California's experience, when people have to file a change in life circumstances, they generally report it right away. California moved to a system that was mostly electronic, and that has really been helpful in getting people to modify their changes when it's necessary. Most people, when they're on Medicaid, their income doesn't change from year to year, especially the children, the elderly, and the disabled. So there are certain people who might be in this category of maybe they're eligible one time and not another, but not always. Anyway, so the bottom line, and hopefully what you got out of this conversation today on the business of healthcare regarding Medicaid, is how complicated and multifaceted Medicaid really is. So if you're one of the people who jumps to of course we shouldn't be spending on all this money on healthcare for those people, why don't they get a job? Or whatever else your reasoning might be for being supportive of the proposed repeal and replace, I would just encourage you to make sure you understand all the aspects of it, get a better handle on who are the people that you know who are your friends, your family, your neighbors who are currently receiving Medicaid benefits. I guarantee you would be surprised. I know it for a fact. I do a lot of work in this field, and I think that a lot of people in the general public have an idea that all of those people who are collecting Medicaid look a certain way, they live in a certain area, they live a certain lifestyle. It's really not how it is. So many things have changed recently. It used to be if you had a job, you had insurance. So the people who were on Medicaid were primarily the people that didn't have jobs. So why don't you get a job? Well, there's lots of people who work at jobs that don't provide health benefits, or people who work multiple jobs and don't put in enough hours at one or the other to qualify for the health benefits program. And it's not because they're lazy or stupid. That's how their life is currently aligned. There are people who are able to take advantage of some of the medical miracles that have been provided in this day and age, whether it's your grandma or your elderly neighbor or your cousin's mother who is being taken care of by some advanced life extending care, maybe a handicapped child who is able to attend school because they have high quality medical care at home to make sure that their condition is properly monitored. So might be real surprised where your Medicaid dollars are going. I am going to wrap it up there. I encourage you, if you've got questions you'd like to have addressed, either comments or feedback about the programming, I'm on email at habanero@wusb.fm. And you can also reach me at my office. Obviously, I'm not there right now. 631-244-5661. And I welcome your comments, feedback, and suggestions for future topics.